Hi, my name is Dr. Chen from Tsihui Mental Hospital in Kaohsiung, Taiwan. I'm specialized in pediatric psychiatry. The topic I'm going to talk about is attention deficit hyperactivity disorder. Attention deficit hyperactivity disorder, which is also called ADHD, is one of the most common neurodevelopmental disorders in children. Although it's often considered as a childhood mental disorder, new research had found that many of children with ADHD continue to suffer from psychiatric problems in adulthood. Therefore, it's now considered as a more chronic condition, which requires adequate treatment to reduce risks of other psychiatric comorbidities or psychosocial impairments in long term. Fortunately, ADHD is one of the most treatable childhood mental disorder, and there have been more than 50 years of treatment experience for ADHD in pediatric psychiatry. Symptoms of ADHD include problems of two main categories. First, inattention, and second, hyperactivity, impulsivity. The following slides show diagnostic criteria of ADHD in DSM-5. There are 5 criteria from A to E in DSM-5 for ADHD, and the criterion A describes main symptoms of ADHD, inattention, and hyperactivity, impulsivity. Criteria A in DSM-5: a persistent pattern of inattention and/or hyperactivity, impulsivity that interferes with functioning or development, as characterized by 1 and/or 2. The first one is inattention. To fulfill criterion of inattention, there must be 6 or more of the following symptoms that have persisted for at least 6 months. To a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. First symptom often fails to give close attention to details or make careless mistakes in schoolwork, at work, or during other activities. Second, often has difficulty sustaining attention in tasks or play activities. For example, has difficulty running focused during lectures, conversation, or lengthy reading. Third, often does not seem to listen when spoken to directly. For example, mind seems elsewhere, even in the absence of any obvious distraction. Fourth, often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. For example, start task but quickly loses focus and is easily sidetracked. Fifth, symptoms often has difficulty organizing tasks and activities. For example, difficulty managing sequential tasks, difficulty keeping materials and belongings in order, disorganized work, has poor time management, or fails to meet deadlines. 6. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort, for example, schoolwork or homework. 7th, often loses things necessary for tasks or activities. For example, school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, mobile telephone. Eighth, is often easily distracted by extraneous stimuli. Ninth, is often forgetful in daily activities. For example, doing chores, running errands. For hyperactivity and impulsivity, to fulfill criteria of hyperactivity and impulsivity, there must be 6 or more of the following symptoms that have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. First symptoms: often fidgets with or taps hands or feet or squirms in seat. Second, often leaves seat in situation when remaining seated is expected. For example, leaves his or her place in a classroom. Third, often runs about or climbs in situation where it is inappropriate. Fourth, often unable to play or engage in leisure activities quietly. Fifth, is often on the go, acting as if driven by a motor. For example, is unable to be or uncomfortable being still for extended time, as in restaurants. 6. Often talks excessively. 7th, often blurts out an answer before a question has been completed. For example, completes people's sentences. Cannot wait for a turn in conversation. 8th, often has difficulty waiting his or her turn. For example, while waiting in line. 9th, often interrupts or intrudes on others. For example, butts into conversations, games, or activities. May start using other people's things without asking or receiving permission. Criteria B, several inattentive or hyperactive impulsive symptoms were present prior to age 12 years. Criteria C, several inattentive or hyperactive impulsive symptoms are present in 2 or more settings. For example, at home, school, or work, with friends or relatives, in other activities. Criteria D, there is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. Criterion E, the symptoms do not occur exclusively during the course of schizophrenia or other psychotic disorder, and are not better explained by another mental disorder. For example, mood disorder, anxiety disorder, substance intoxication, or withdrawal. To be diagnosed with ADHD, all the criteria from A to E must be met. For example, if above symptoms only present in one setting, such as only at home, or occur during course of anxiety disorder, diagnosis other than ADHD should be considered. There are three subtypes of ADHD. The first one is combined type. If both criteria of inattention and hyperactivity, impulsivity are met for the past 6 months. This is the most common subtype. Second subtype, inattentive type. If only criterion of inattention is met, but criterion of hyperactivity, impulsivity is not met. This subtype is more common in girls. Third subtype, hyperactive, impulsive type. If only criterion of hyperactivity, impulsivity is met, but criterion of inattention is not met over the past 6 months. This is the less common subtype. Symptoms of ADHD can cause impairment in all areas of functioning, but mainly in cognitive development, academic performance, social interaction, behavior, and emotional problems. Patients with ADHD also frequently suffer from problems in executive function, which involve the ability to plan your work and work your plan. Presentation of ADHD symptoms can be quite different between males and females. Girls with ADHD present with more attention problems, but the less disruptive behaviors and the more internalizing problems, such as anxiety and depression. Therefore, symptoms in girls may be under-recognized. Boys with ADHD present with more behavior problems, which often lead to clinical referral. Presentation of ADHD symptoms can also be quite different with different age. In preschool children, hyperactive presentation is more common. The symptoms of hyperactivity tend to reduce with age. In elementary school children, the combined type is more commonly diagnosed, and the inattention type is more common in middle and high school. Worldwide prevalence of ADHD is estimated to be 5 to 12% with significant variability. ADHD occurs more commonly in boys, and the male to female ratio is about 1 to 2 in large epidemiological studies. Median age of onset for children with current ADHD is 6 years. However, children with more severe symptoms of ADHD may present earlier at the age of 4. Family history of ADHD, male sex, low socioeconomic status, and young age are associated with a higher prevalence of ADHD. Etiology of ADHD is complex and most likely involves both genetic and environmental factors. Studies have shown that ADHD has strong genetic factors and is transmitted in families. A recent study found that genetic factors accounted for 60% of the heritability. Genetic studies have identified many risk alleles associated with higher risk of ADHD. For example, D5 dopamine receptor gene, DRD5, and the serotonin transporter gene. Developmental factors may also be involved in etiology of ADHD. For example, subtle brain damage caused by infection or inflammation during important window of brain development during pregnancy. Poor parenting skill is not considered to be the cause of ADHD, but may exacerbate symptoms of ADHD. Structural studies found that ADHD children have significantly smaller brain volumes, especially in dorsolateral prefrontal cortex. Neurocognitive studies also identify patterns of executive dysfunction in patients with ADHD, which reflect abnormalities in the functioning of prefrontal cortex. New brain imaging techniques, such as functional MRI or PET scan, further show that hypoperfusion in frontal and possibly striatal areas. This is a picture of PET scan for ADHD patients versus normal people. We can see that patients with ADHD had lower global cerebral glucose metabolism, which may indicate poor overall brain function. Therefore, the evidence is now quite clear that ADHD has strong biological basis, not just something psychological. Many neurotransmitters have been associated with attention, but the noradrenergic and the dopaminogenic systems are most important in ADHD symptoms and are also targets for medication treatment. ADHD is a diagnosis primarily made by history, often by caregiver or school teachers. Some children with ADHD can appear calm in novel setting with an adult one-on-one, especially strangers. Therefore, it's important to collect information from parents, school, and other caregivers to make diagnosis. A very important way to collect caregiver observation is by using standardized rating scales. SNAP rating scales, which covers all symptoms in DSM-5, with a rating from 0 to 3, is one of the most commonly used rating scale in clinical settings for ADHD diagnosis. This picture shows SNAP rating scales for ADHD. The first 9 symptoms describe symptoms of inattention from DSM-5, and from 10 to 18 symptoms describe symptoms of hyperactivity, impulsivity. The last 8 symptoms describe associated emotional or behavioral problems. Patients with ADHD has a high rate of comorbid psychiatric disorders. 50% of clinical samples have oppositional defiant disorders or conduct disorders. 25 to 30% have anxiety disorders, and 20 to 25% have learning disorder. The manifestation of ADHD symptoms changes over the course of life. Just as normal children develop better attention and impulse control over time, but in much slower pace. Moreover, improvement in attention may still fail to meet demands of more challenging environment, such as more complicated social environments or more difficult academic tasks. Childhood ADHD severity and treatment significantly predicts persistence of ADHD in adulthood. Hyperactivity is the most likely symptoms to be outgrown. Most persistent symptoms include inattention, distractibility, disorganization, and failure to finish things. Up to 60% of children continue to suffer from symptoms in adulthood. The ratio of female to male becomes much equal, about 1:1 in adult population. The prevalence of adult ADHD is about 1%. Males with ADHD are more likely to develop polysubstance abuse and adult antisocial behaviors. Adults with ADHD may struggle with job performance, marriage problems, difficulty with schedules, and money management. Girls and women with ADHD have higher rate of unwanted pregnancy. Adults with ADHD may present with significant self-esteem issues and feeling of hopelessness with ongoing difficulties in managing everyday life. Therefore, adults with ADHD may suffer from higher rate of major depression or anxiety disorders. Effective treatment, including cognitive behavioral therapy and medications targeting at attention or mood, significantly improves quality of life in adults with ADHD. Because ADHD is a chronic and pervasive condition affecting almost all areas of functioning, comprehensive and flexible treatment plans are required to adapt challenging needs over time. Psychoeducation about this condition is very important in the beginning of the treatment, because the commitment of patient and family is essential for compliance of the treatment. Treatment planning has to be individualized, and personal responsibility of managing disorders must be discussed gradually and periodically with the children and adolescents. There are two main treatment modalities in ADHD: medications and behavioral treatment. Behavioral treatments are based on social learning theory. Behaviors that are reinforced increase in frequency, and those are not reinforced or are punished tend to extinguish. A number of practical behavior treatments can be given to parents from first contact with the family, including star charts for target behaviors, clear house rules, written or pictorial instructions, and contingency for doing various things. This picture shows an example of star chart for behavioral therapy in children. Star charts reward desired behaviors with a star or sticker. When a child achieves the target behavior, he or she can earn a star to put on this chart, color the space, or use a sticker. If the children cannot read, you can draw pictures of desired behaviors as shown in the picture. This picture shows an example of clear house rules. A clear house rule is important for ADHD children as it builds consensus, provides structure, clarify expectations, and serve as a visual reminder of expected behavior. Again, if the children cannot read, you can draw pictures of desired behaviors as shown in the picture. With more time and more effort, more refined intervention, such as home token economy or a daily report card, to tie school behavior to home reinforcement may be used. Availability of programs for providing parental training may be different among different countries. Many psychiatric drugs have some benefit in ADHD, but only a few of them are FDA approved in United States. Medications can be used directly for core symptoms of ADHD, such as attention, or targeted at associated symptoms of ADHD, such as aggression or irritability. The medications for core symptoms of ADHD are categorized into two groups: stimulants and non-stimulants. There are many different drugs that can help to improve attention or reduce hyperactivity, but I will only introduce two most commonly used drugs in Taiwan. The first one is methylphenidate, which belongs to class of CNS stimulant. It inhibits the reuptake of dopamine and norepinephrine, therefore increasing norepinephrine and dopamine levels in the prefrontal cortex. The most common and concerning side effect of methylphenidate is poor appetite. Therefore, regular monitoring of body weight is necessary for those under treatment of methylphenidate. Atomoxetine is a non-stimulant and belongs to class of selective norepinephrine reuptake inhibitors. It also has potential to increase norepinephrine and dopamine levels in the prefrontal cortex. It is considered less effective than methylphenidate, but has fewer side effects. In Taiwan, atomoxetine is often used as a second-line medication for ADHD. One of the most important studies investigating treatment efficacy of different treatment modalities for ADHD is MTA study. MTA study, which stands for multimodal treatment study of children with attention deficit hyperactivity disorder, was carried out by National Institute of Health in United States, which is an agency of United States government. MTA study is a 14-month randomized clinical trial for children aged between 7 to 10 years. The result of the study was published in 1999. Participants with ADHD were randomized into 4 groups of treatment. First, combined therapy with both medication and behavioral therapy. Second, medication treatment only. Third, behavioral therapy only. Fourth, regular community care. In regular community care, participants also received some forms of therapy in the community, which may also include medication or just some advice from clinicians. The result showed that all 4 groups had a significant improvement in symptoms of ADHD over time. However, combined therapy of medication and behavioral therapy had highest efficacy, and this is followed by medication alone. Behavioral therapy was better than regular community care, but the difference was not statistically significant. The most important conclusion of MTA study is that it's best to provide both medication and behavioral therapy for ADHD patients. But medication is a very important part of treatment. In summary, ADHD is one of the most common neurodevelopmental disorders in children, and it can lead to psychosocial impairments in long term, even in adulthood. Fortunately, ADHD is the most treatable childhood mental disorders, and adequate treatment can reduce risks of further psychiatric comorbidities or psychosocial impairments in long term. Combined therapy of both medication and behavioral therapy has best efficacy. But when behavioral therapy is not available, medication alone is also very effective and a very important part of treatment plans. And these are the reference for the information in this lesson. Thanks for your attention.
小明啊，莫阁耍啊啦，坐好啦，小等下你就跋倒。足痛，足痛！我毋是叫你莫耍啊吗？来，我看嘛咧，有要紧无？什么时阵要带我去钓鱼啊？你要想要去钓鱼，前摆带你去拢唔专心钓，唔是一直牵石头，就是甲钓竿举起来当做马鞭一直摔，甲钓竿拢摔歹去啊啦！无钓竿无法度通钓鱼啊！我甲你讲对不起啊，阿爸你带我去动物园算好无？动物园？动物园有一寡所在袂用的饲动物的，你就是袂听话，害我去用内的管理员骂。阿明啊，你这个囡仔真正是唔听话啦！ 一出现就骂囡仔，还是发生什么代志啦？鱼肚仔内面哦，两尾红金鱼变乌鱼，拢变多要死啊啦！发生什么代志？你家己问你的宝贝仔囝啦。小明，囡仔咧？哦，又搁在弄破地杯啊啦！你甲我出来啦！哦，你这个囡仔叫你莫车齿，你拢讲袂听。我问你，是安怎样鱼肚仔的水会变乌色的？我本来想要洗乌白盘顺续，甲迄金鱼仔变乌色的。哪会知影金鱼仔袂甘要我洗，就死翘翘啊！吼，你这个戆囡仔，要洗木盘应该摕去水台啊洗啊！金鱼本来就是金色的，无法度人变乌色的，你知无？我知啦。哦，你这个囡仔真正是伤脑筋呢！唉，叫你较安静的，你就是静袂落来。下面你要搁去对，你过来。你这呢活骨无须得定。来，你徛这10秒，莫等我10块给你，好无？50。好，50。计时开始，1、2、3、4、5、6、7、8、9、10，时间到50起来。嘿，你算遮紧？50块起来。好，50给你。你唔通搁再乌白食物件哦。系啦，谢谢爸比，哈哈。这个囡仔拢你想歹去的啦，莫啥物拢怪我好无？你嘛有责任吗？昨我带小明要去上学，老师甲我讲，恁家的小明上课的时阵唔专心，还会创伫同学影响人上课，中昼唔困，还搁在学跳北家将，害全班发气。你搁举起要创啥？因为我的同学爱看我表演跳北家将，所以我就跳互因看。迄是我聪明厉害所在啦。爸比、妈咪，你看我安尼有声大仙角、大神仙无？你看啦，唔认真啊读册，全学拢学一寡这无路用的啦。你搁假，我就甲你洗落，看你偌大仙。哎呦，有人生气啊，绕跑，哈哈！你要搁去倒一啊啦？安娜达，什么安娜达啦？无啦，我是咧叫你心爱的安娜达啦。咱小明这个囡仔伤过好记住，也正行，无须得定。敢会是人伫咧讲的过动儿？若是过动儿不要紧，有救啊啦！我听咱隔壁迄个陈太太伫咧讲，囡仔若唔专心，坐袂牢，无耐性像你讲的过动儿，有一种洗手的药水，洗几摆就有效啊！也可会改变体质，嘛有去用喷的哦。世间上哪有遐尼神奇的药水？你当作是仙丹哦？迄是一寡赤卡仙仔啦，拢讲是因5代祖先留落来的偏方，伫咧骗人的啦。我看可能是咱前出世欠伊的，这出世要来糟蹋咱的，带来去问神明改运。也是请先生帮小明来改名才对哦。我明仔载就来去问陈太太，看伫倒位买药水，想要来试用看卖咧啦。世间上无简单啦，问神明改名较实在啦。小明啊，你又搁咧整什么物件啦？ 啊，你灶骹有伫咧煮啥物物件无？啊，危险啊，危险啦，赶紧啦！
注意力不足过动症又叫做 ADHD 或过动症，是儿童最常见的神经发展疾患。其主要的特征呢，是在不同的场合出现与其年龄不相符合的注意力不足、过动及冲动等症状。那这样的行为呢，可能会造成父母以及老师在教导上相当的费心，父母的情绪也可能会因此而常常受到影响。在台湾呢，注意力不足过动症的盛行率大约是7%，在男孩身上会比较常见。那有的人呢，会以注意力不足为主，大约占30%左右。那有部分的人呢，可能会以过动及冲动的症状表现为主，大约1到2成。那最常见的其实是所谓的混合型，就是既有注意力不足的问题，又合并有过动及冲动的症状。好，目前呢已经有共识的呢，其实注意力不足过动症是大脑发展的问题。那最有效的治疗呢，包括药物治疗以及认知行为治疗。其他的治疗呢，尚未得到非常良好的证明。通常6岁以下的孩童呢，一般来说会还是以行为治疗以及家长和教师训练为主。6岁以上呢，会建议使用药物以及搭配孩童的认知行为治疗及家长的训练。那家长的训练以及孩童的认知行为治疗呢，对小朋友来说也是相当的重要，所以会建议呢，爸爸妈妈能够和医师一起讨论，能够参加这些认知行为治疗的课程，不单单只是靠药物。
啊，你我伫咧爬树啊，你会爬落来啦！宝贝啊，紧落来，紧落来，真正要睇你治病啊，赶紧落来！我落来啦！哎呦，我足痛！哦，你足无小心的，我看嘛咧有要紧无？来来，我带你入去，互先生解晕。小朋友啊，你调好，我来给你看嘛咧。有可能是卡着音啦，也是前世人的冤亲债主行无完，才会规工扑扑跳，安尼无须得定。来来，我请神明来帮你解解。风过，地主虔诚拜请着你尊神灵的神空公台，神威坚毅配李小民小地主来消灾解厄，压气凶神恶煞。天清的，地灵灵的，拜请五湖四海众神明，速速来端前，端前要分要四个加槟榔。嘿，拜请大仙的王爷公咧，细仙的王爷囝咧，我是加减请，恁若有听着我伫咧请，恁着加减行咧，有来着有食，兼有领，无来着拢无食，拢免领，铁。即马要来。这解这个五鬼煞，五鬼，头壳卜两雷，胸坎拿楼梯， 巴肚拿水柜，2只手亲像金刚腿，2只骹敢若亲像草尾腿，犯五鬼会万事不顺，身体会破病。
啊，犯五鬼是要用什么做来治啊？
要若讲犯五鬼吼，就爱请本中段西公亮啊来用纸人制解。嘿，制图23分，制纸23寸，暗时啊失眠，买手机啊拢唔困，这时啊你着头昏昏，脑顿顿铁。嘿，猪仔囝、狗仔囝咧，唔食咧唔食饭，你着腰甲二准铁。好来，安尼好啊！我甲你改这好势啊，改这好势啊。改运真正有效哦。小明乖乖啊，徛点点无乌白走啊。爸比，我目睭用着涂刷粉啊，要安怎走？改运无效啦。我伫个天才儿童协会听讲吼，抹精油是香皂有效，囡仔会较镇静啦。有啦。我知影出门入门拢爱洗手，较袂着肠病毒啦，阁会防止冠状病毒啦。这个囡仔戴天命要来糟蹋恁翁仔某诶，我无法度通替恁排解啊！恁另请高明，请了请了。拢你啦，改运有效，也毋是个哭哭撞。咱小明真正是过动儿哦！哎哟，我看一大人哦，袂晓教囡仔伤过放任啦，放互伊哭哭撞啦。来啦，我只有3项法宝会使试看嘛呢啦。头一项，蓝麻配大；第2项，草煎3更。啊，若阁无效吼，请用绝招业主好事讲。哎哟，根本就无啥物过动儿啦，是囡仔吼较活骨尔，也是讲学校的老师无耐心来教学生啦，囡仔吼才会歹教啦。阿 Q 伊啊！你讲这点我无完全认同哦。哎哟，老王的啊，安怎讲无认同啊？咱伫厝内家长无教好咱的囡仔，你叫学校的老师要安怎教？囡仔伫学校无乖，老师若较大声甲伊骂，也是处罚。当去甲家长讲。有一寡较无理解的家长，隔工就到学校去骂老师。囡仔无乖袂读册嘛，要怪老师。老李个啊，我看你着带去看医生哦，去放电放放的就好啊啦。李长伯啊，你好。阿伯你好。好，大家好。拄则恁大家在讲的，我拢有听到啊啦。老李个啊，莫阁听信偏方啊。囡仔会随着成长来改变，若是比较活泼，大汉确实会稳定一寡。啊，若真正过动症，有坐袂调，注意力不佳，袂专心，会影响学习。若无治疗，大汉也可能容易来做毋对。所以一定爱看医生，偏方唔通用啦。有一寡知名的企业家、运动员细汉的时阵是过动症，若是找到兴趣，按兴趣去学习，未来发展就会无唔对。问医生，你就会知啦。李长伯啊，你讲的有理哦，感谢你哦，我带来去看医生。小明，走，我带你去逛街，哈哈哈。
医师啊，我请教你吼，迄吃这个也养，啊吃那个也养哦，啊安尼治疗敢会好哈？
好， 那其实这个注意力不足过动的小朋友呢，他们如果没有经过好的治疗，可能会出现一些低自尊、低成就，未来就业可能会发生困难，甚至有些人会出现一些法律的问题，也有较高比例可能会使用一些不好的物质。不过，爸爸你先不用太担心，研究告诉我们，如果经由好的治疗，小朋友未来呢一定要可以发展得非常好。那而且呢，治疗后当下的问题行为也会减少非常的多。其实世界上有很多有名的人，他们过去也曾经有过这样的问题，譬如说奥运的金牌选手飞鱼，以及呢美国非常知名的歌手亚当李维，他们从小都有被诊断出注意力不足过动症，但是有良好的治疗，未来一样可以发展得非常好。
医师啊，我请教你吼，我有试过迄个精油香皂吼，甲算命解运吼，逐工就去放电，哪会安怎拢无效哈？
其实爸爸刚刚提到的那些呢，都不是正统的治疗。我们其实会建议呢，要带小朋友尽快去儿童心智科做一个完整的评估，因为很多注意力不足过动冲动的小朋友，其实不是只有注意力不足的问题，很多可能会合并一些情绪方面的困难、人际互动的障碍或学习方面的障碍。只有接受完整的评估呢，才能够帮助我们更了解这些小朋友。不单单只是针对他注意力不足的问题去做协助，我们也可以安排一些课程，来帮助他，让他的情绪方面能够调整得更好，那也能够让他在人际互动方面呢，能够持续不断的进步。其实越早的治疗呢，这些小朋友他们可以适应得更好，所以爸爸妈妈不要担心，让我们一起来尽快的帮助这些小朋友，他们未来一样可以非常的成功，发展得非常好。